And welcome to the Children, Adults, Health and Wellbeing Policy Development and Scrutiny Panel. And I'm sure that, well, hopefully the weather will hold and we won't be sort of drowned out by the noise of rain, etc., as we proceed through our meeting. So, welcome everybody. I'm just going to go through the panel members and ask them to introduce themselves. And then if other people are speaking in due course, if then you could introduce yourselves then. My name is Dina Romero. I'm a councillor in Southdown and I chair this panel. Please.
Good morning. My name is Liz Hardman. I'm Vice Chair of this committee. I'm also the Ward Councillor for Porton.
Hello everyone. My name is Anna Box. I'm Councillor for the Chew Valley and I'm subbing today. Thank you.
David Harding, also Councillor for the Chew Valley Ward.
Michael Orton, I'm the Ward Councillor for Middlesbrough Norton North.
Jess David, I'm Ward Councillor for Moorlands in South West Bath.
Hello, Councillor Joanna Wright, Lambridge Ward.
Chris, can you use your microphone?
Christopher Batten, National Education Union Representative, non-voting member.
Thank you, Chris. And we're supported... Oh, sorry, Leslie.
Morning, everyone. I'm Leslie Munsell. I'm the Councillor for Radstock.
Thank you. And we are supported by...
Good morning, everyone. My name is Mark Downford. I'm the clerk to the panel. Thank you.
Good morning. I'm Kerry Williams, and I provide the panel with scrutiny officer support.
Thank you, everybody. So apologies for absence and substitution. So we have apologies from Councillor Paul Crosley, Councillor Onkar Saini, Kevin Burnett and Councillor Barrett Pankania, and we have substitutes Councillor Anna Box and Councillor Jess David. So welcome everybody. Declarations of interest.
I'm just declaring that in my full-time role with the Community Catalyst, I work very closely with adult social care, and obviously that's one of the issues being discussed today. So.
Thank you very much, Michael. Urgent business. The only business that I wanted to draw the panel's attention to is an update on the work of the Task and Finish group, and that update I'll bring to the next meeting of the Children's Focused Scrutiny Panel, which will be in October. So the next item is the public or councillor statements and questions. I know that we have received some which I think have been answered and then they have been responded to. Okay, so thank you for that. So now we move on to the presentation, which has actually been deferred until the next meeting. I'm very sorry, I've literally just read that, so my apologies. I'd now like to move on to Alison Bourne and ask her to pick up on any other matters that are not included within her Cabinet report, or indeed if there's anything she wishes to draw our attention to in that report.
Okay, thank you. Yes, my Cabinet report was sent out in advance, so hopefully you've all had time to read it. I don't think there's... Yes, quite a lot of it is business as usual and things progressing rather than there being sort of major issues that we are dealing with at the moment. Newton House, we are continuing to work with the relatives on future provision of respite services, so that's ongoing business. Community support recommissioning, we can't really say much about that at the moment because it's a live process, but that is in train. Yes, there's an update on the regulated services. That's the two community resource centres that we run in Baines that we took back in-house in 2020, and also the 5 extra care schemes that transferred across at the same time. And I suppose it's just worth saying that Suzanne and I do periodic visits to services, and we visited the 2 care homes in August, and I was really pleased to note the progress that's been made. I mean, I don't think you turn services like that around overnight, and it's been quite a long slog, but we have made a lot of progress in really improving those services quite considerably since we took them back in-house from Serona, when they chose to hand them back to us. And then there are a few public health items. The cool spaces, is you may remember during the cost of living crisis and the energy crisis that we developed warm spaces for people to go to when they needed to. While we had the heat waves, we started a process for developing cool spaces, and obviously that's now in place. So in future, when we have heat waves, we'll be able to ramp that up again. And then there are other areas in public health, which again, I think, as is always the case, show the breadth of the public health activity across the council and the range of areas that they work on on behalf of our residents. So I'm happy to take any questions.
Thank you, Alison. So do I have any questions? I'll go first to Liz.
Firstly, the Newton House update. Alison, you've referred to it very briefly, but all that is in the minutes is in your report is the minutes from last time round. So I just wondered, just as an update for us, are things moving on? I know Suzanne is having monthly meetings with the carers, so I just wonder, can you add a little bit more so that we're staying on top of that? There's lots of good things happening, but I'd like more information about the Be Well. Who's in charge of it? And maybe I've missed out on something, but we've got a Be Well Baines, whole system improvement. Could you explain more? Who's in charge? And then the cool system, when I saw this, okay, we've come past it now. And I thought, this is a fantastic idea, but there are only 5 kind of outlets for people to use. So just thinking about next summer, and obviously we've had an incredibly hot summer, are there any plans in place to make sure that, you know, nearer the time, that we're going to look for more cool spaces for our residents? Thanks.
So around Newton House, we've agreed, just so people know, I'm Suzanne Westhead, the Director of Adult Social Care. We've agreed with the families. We met with them again in August, but all of the families, rather than just the dedicated 4 families who are working with us, and agreed that we would go out to tender. So it'd be a procurement, but it's an all-age residential, an all-age respite service. So we're busy now scoping that, but families have agreed to help us with that as well. So we will have to do that over the next year to have us in a position for September next year to have an all-age respite service. We go out to procurement. Now, I'm sure that the provider that's there now may also go through that tendering process. I have no idea. We'll put a specification out, and the team are working now with the family on what that timetable will be. So I'll need to come back probably in November with an update on the timetable. So we know it's September, but I need to show you what we need to do to get to that.
Thank you. That's very thorough. Thanks.
Okay, with reference to the Be Well Baines work, I mean, that's a fairly significant piece of work that Public Health has been working on for a while now, and they've had a couple of quite major engagement events to scope out the work and to identify the priorities. So I'm going to hand over to Becky to say a little bit more about precisely where we are with that.
Oh, there we go. Thank you very much, and I'm going to hand over to Marcia in a second. So Be Well Baines is the Council's health improvement framework. So whereas previously we would have had a tobacco control strategy, a healthy weight strategy, a physical activity strategy, this Be Well Baines approach recognises that there are lots of commonalities to different behaviours and lots of commonalities to things that help people live healthier lives, whether that's not smoking, drinking in moderation, taking physical activity. So Be Well Baines is a whole system approach. We're trying to bring together our means of tackling those particular health improvement topics, and doing it very much in an upstream way as well, so that it isn't just up to individuals to make changes to their behaviour, as well as that it is looking at how can we make the environment around people and the policies and the places in which people live and work, how can we make it much easier for people and support them in their decisions to live healthier lifestyles. So it's led by Public Health. It's led jointly by Marcia Bergam, who is a Public Health Principal, who is here also to talk about, who has a paper on the Health and Wellbeing Survey in a little while. So, and it's also led jointly by Marcia with Annette Luca in the Public Health team. So I'll just ask Marcia if she'll just give a bit more information about Be Wellbeings.
Thank you. Yeah, so we have a very engaged steering group now who is leading this work, and it brings together partners from a range of internal council departments as well as external stakeholders as well, bringing together all the domains that Becky has just mentioned. We have really focused on setting up a really clear governance and reporting to make sure that we have oversight of all of the work streams that are interconnected. Part of that has also been working, planning to work with the community and doing some work with the community to work in a white way, just in recognition of the needs within that community. So really getting and identifying capacity to be able to work with that community on those determinants of health. In terms of the focus and priority of children and young people, we've also got a Children and Young People's Network who will be really focusing on implementing the Education Attainment Gap Action Plan, recognising those wider determinants and the impacts on health of children and young people. So the focus has really been setting up the kind of governance to ensure that the work is pulled together and is on track, and we're also going to be working on making sure there's a clear monitoring and reporting framework so that we can measure the progress being made and any barriers to that as well.
Anna and David, and then
and in relation to the cool spaces, yes, I mean, I think this summer with, several heat waves, it became very clear that actually it's not just cold that's a problem, it's potentially heat that's a problem, particularly for people who live in houses where it's very difficult to cool down and people who can't afford air conditioning and various other things. So from a public health point of view, we recognise that that's something that we need to work on. What we've done now is we've set up the foundations. We've got a framework for it so that as we move into next summer, we'll be working with the communities to identify more people who are prepared to identify as cool spaces that people can use. So it will be a piece of work that's gone quiet for the moment, but will be picked up again as we come into next spring and summer.
Thank you. Anna, then David, then Jess.
Thank you, Chair. Mine's a slightly technical question, so apologies. The 10-year work plan for the NHS was published in July, and they've put a lot more of emphasis on holistic care, preventative care, lack of hospital escalation. Public health is a massive part of that in preventative medicine. I think they talk about illness to, like sickness to wellness or something like that. Anyway, something that was fascinating for us as an NHS trust was around, because I work for the NHS, was around funding. So instead of it being fund per service, they're now going to change the model to be a year of payments. Sorry. So my question to you guys is are you incorporated in that as a public health body council? Because to me, you play a key role in stopping people from getting to the NHS, let alone getting to hospital. So will you be access to this funding in the next 10 years?
Shall I pick that? Yeah, thank you. I'll start with that and then probably hand over to Laura. So yes, we are working incredibly closely with our NHS colleagues and as Director of Public Health, working very closely through the region with other Directors of Public Health in the South West and the Regional Director of Public Health, who works jointly across the NHS and with Department of Health and Social Care. So working very closely in terms of planning, in terms of looking at the various programmes that we have that are happening in Bath and North East Somerset and through our ICB, and what are some of the commonalities between those, working very closely through our Integrated Care Alliance, in terms of thinking what is it that we can do, how can we work effectively across the whole system to have an earlier focus on it's from illness to prevention, as you say, while also recognising that there are always acute pressures in the system that always need to be dealt with. I'll probably hand over to Laura in terms of picking some of that up, but yes, we're working incredibly closely, both at a practical level and also at a policy and planning level.
Thank you for the question. Laura Ambler, Executive Director in the BSW ICB. So yeah, the 10-year plan has got 3 shifts that we've talked about before. So there is that hospital to community, so moving care closer to where people are at home, sickness to prevention, and analogue to digital. So we are focusing on all of those. And when you wrap them all up, prevention and the whole system approach that public health colleagues have described is exactly the spirit of the direction that we need to be going in. So you'll all remember that we had an integrated care model that puts the person at the centre and actually achieves all of those three aims. So in a way, we're a little bit ahead, if you like, ahead of the NHS 10-year plan coming out with what we did through our integrated community-based care programme. So how we commission as a strategic commissioner, we've commissioned all of those community services through that programme. We are working alongside the local authority as a co-commissioner in that programme, but we also need to align commissioning that might be done by public health, so things like drug and alcohol or any other programmes that there might be. There's different ways of integration, isn't there? You can align to make sure that you are actually all pivoting and facing in the same direction. So we work really closely, particularly around joint commissioning. And the final thing to say around that is Suzanne and I work very closely as well on something called the Better Care Fund. So the whole point is to be very holistic and keep those key central objectives in mind whenever we do any type of commissioning, whether we're doing that on our own or whether we're doing it jointly, always exploring those opportunities. So I hope that helps a bit in terms of how we try and get more bang for the buck, if you like.
Thank you, Laura, and thank you, Becky. David and then Jess.
Thank you. What specific things will happen in the rural areas? You know, different pressures, different demographics often. Will you be doing work around that? And would we be able to see what that work is?
Can I just clarify, Councillor, is this in relation to Wellbeing? Okay.
So in terms of the focus initially for the first 2 years, we are looking at the community in Twerton and Whiteway, but that's not to say that we're not looking at the needs of the whole area of Baines as well. And as Becky mentioned, some of those initiatives that are happening already will continue to be Baines-wide, and we'll be continuing to support all of the population, particularly in the rural areas, with their health and well-being in certain initiatives. So one example for it is around the breastfeeding that happens in the Radstock-Soma Valley area. Things that are existing will be continuing, and we'll be continuing to listen to the residents and look at the needs within the whole population of Baines. But we will just be focusing with a particular target around the Twerton and Whiteway area with a different kind of model in terms of going into that community and really listening to their needs and looking at the assets within that community as well. But then we hope to replicate that across the wider area going forward as well. But it's not to say that work won't be continuing within those rural areas.
And if I can, thank you, Marcy, if I can add to that as well, we will still have a tobacco control action plan, and we will still have a physical activity plan and a food and health plan. And all those, and our education attainment gap work has a big focus and recognises the difficulty on living in rural areas and difficulties around transport and young people being able to access transport. So there are actions in there where we're looking to work particularly with WECA. So most of those plans do have a district-wide, and we'll be focusing on rural areas as well as the sort of more suburb areas of Bath. I hope that helps answer your question.
Yeah, thank you. Be good to hear perhaps about some of those in the future.
Be delighted to, yes, that'd be great. Thank you for the suggestion.
Can I just add that while there's a geographic focus for Twerton and Whiteway, there's also an age group focus across the whole authority for the children and young people's work. So it's a combination of, locally focused and more broadly focused, depending on which priority you're looking at.
I'm sure David will make sure that there is some focus on the rural areas, and particularly the areas that he's particularly interested in. Thank you. Jess.
Thank you. So I just wanted to pick up again on the indoor cool spaces directory, which is really good to hear about. I wondered whether there might be an opportunity to also do a bit of mapping work on outdoor shaded space provision as well, and whether that might be quite a good time to inform the local plan, potentially future tree planting initiatives and things, or even structures that we can put in our public spaces to provide some outdoor shade. So whether or not that's something you're already thinking about, or if you agree there might be an opportunity. And then also on Be Wellbeings, I wondered if our neighbourhood services or parks team are involved in the governance of that, because I can see some real opportunities to, for physical activity in parks. I know that's something that other local authorities have done. Thanks.
Yeah, thank you for both of those questions, Councillor. For the first one, yes, mapping has been done. We haven't put it in the brief, but there is a link which I can send around if useful. So there is a map. I was diving into it this morning to have a look, and you can go into it in quite some level of detail. So it shows facilities across Bath and North East Somerset where there are shaded areas, where there's seating areas, and also highlights where there are cafes and toilets as well for people who want to move out of the heat into an indoor space. So that mapping has been done, and we'll build on that absolutely as time goes on. In terms of governance for Be Wellbeings, yes, that department is a whole council steering group, so there's representation from key parts of the council, which includes parks, because we absolutely recognise the importance of outdoor spaces in helping to keep physically and mentally well. Yeah. Thank you.
Thank you, Chair. David, I'd just like to update you on one...
Would you just introduce yourself?
Oh, sorry. Apologies. Victoria Stanley. I'm Head of Primary Care for Community Pharmacy, Optometry and Dentistry, working for the ICB. David, I'd just like to update you on one small project that has recently started and just in its initiation phase of the local GP surgery in your area, working with local dental providers, aimed at a key cohort of individuals focusing on prevention work with regards to improving oral health. That is a joint project, like I say, between it's actually the primary care network, so the group of GP practices in your area and a local dental provider, taking a group consultation model to teach people around oral health and general mouth care. It's the first time that we've seen GPs and dentists actually collaborate in this manner, so I'm really hopeful that it's actually going to produce some real successful outcomes that will actually improve not only their mouth or general oral care, but links to, like what Becky and the team have been saying today about those wider determinants of health and understanding the link between oral health or good oral health and long-term disease management.
Thank you. It's very interesting to hear. Be good to hear a little bit more about some of the results. Which age group, when they come out, is it adults, children?
I have been told, but from memory, because I didn't expect this discussion today, there's a key cohort that between the professionals involved they have identified who would find it useful. From memory, I think it was adults, but there is a whole heap of work going on across the whole area with regards to children and young people and oral health, as we've probably talked about in this forum on core 20+5 populations.
Perhaps we could have an update, certainly around the children's part, when we have our next meeting in October. Would that be helpful? If there's enough information?
It may... No, probably not at that stage, to be honest with you. So I can link with the providers and see when actually some of the first outcomes will be made available and schedule time in with Mark, if that's okay.
Okay, but hopefully this side of Christmas.
I'll try.
Thank you. Take Leslie first and then
Yes, thank you for the report. I've got a number of questions. I'm going to go backwards through the report. So the holiday activity and food programme, what lessons from the programme are informing future delivery, and how many of these projects are available in North East Somerset and in particular in Radstock? On the Be Wellbeings, what indicators will be used to measure progress across the four core aims? And on the sexual health, if you look at the school survey results, which is later in the papers, it looks like awareness around STIs are going down. So what is happening in schools in terms of health promotion and in fact elsewhere? When I was at Freedom Youth, it was a standard thing that we did with young people, and they were absolutely spot on with it. So it's a question of raising issues for me. Cool Spaces, again, I think it's a great initiative. What outreach is planned to ensure that residents know about these spaces, especially vulnerable residents? The carers strategy, again, it's great. The equality impact assessment has a lot of holes in it. There's lots of not applicables, and I'm still waiting for somebody to explain to me how with non-protected characteristics, sexual orientation and gender identity are not applicable, apparently. So I've got loads of questions which I'm going to send through to the author. But what actions are going to be taken to reach underrepresented carers? For example, Black, Asian, minority ethnic, LGBTQ+ and younger carers. How will this equality impact assessment be monitored and updated throughout delivery? And what mechanisms are in place to ensure carers' feedback leads to service changes? Thank you.
So some of those do you want picked up in the later papers, or do you want all of that to be addressed? Alison, do you want to pick up on the ones that are relevant perhaps to your particular paper, and then maybe the others can be addressed as we go through the relevant papers?
Yes, there was a lot of detail in those questions, Leslie. I'm going to defer to Becky for the Holiday Activity and Food Programme. Becky and Marcia.
Thank you. Marcia will pick it up, thanks.
Thank you. So in terms of what lessons have been learned from the Holiday Activity Food Programme and how we've adapted the programme, we are very strong after every holiday period in terms of getting feedback from children and young people accessing the services, as well as their parents and carers, and also from the local providers who are delivering the services. Some examples that I can think of where we've changed: we do know that older young people aren't so keen in attending activities within their schools, so they are more popular. The trips that we can put on are more popular with those older age range. We've also, in terms of vicinity to parent and carers, we know that actually for the younger age range, the familiarity they have with the school and being able to put provisional within their schools is really popular. We have also strengthened the offer for SEND children and young people as well, just in terms of them being able to access some of the mainstream activities that are being put on. So increasing the access and the support available to enable them to do that. There's been a variety of different activities that have been put on over the last couple of years. We know that previously there was a bit of a heavy sports focus, so we've really adapted it to ensure there's things more around theatre, arts, creative work as well. So that's the kind of some of the tangible things that we know that we've changed in regard to feedback from children and people and parent carers. But we will continue to ensure that that's a key part of the routine provision for that service, those services. In terms of some of the activities within the Soma Valley area, we can share the link to the Holiday Activity Food Activate website, and that will give you a clear list of everything that's going on throughout Bath and North East Somerset. So the summer programme is now finished, but we do promote the link when we'll be planning the Christmas activities soon, and we will ensure that you can have that link and you can look up where the activities will be, and they do include across Baines, including the Soma Valley area.
And shall I pick up in terms of sex and relationships education awareness in schools and with young people, and you can add anything, Marcia, if there's anything that your team adds. So awareness is raised through a number of different routes. There's the science education curriculum and the personal social health education curriculum that teachers deliver. We have very strong working relationships with all of our school nurses who work in primary and secondary schools, and They both can support teachers in the curriculum, and they also run sexual health clinics within most of our secondary schools, which are drop-in clinics for young people who may wish to talk with somebody around relationships and sexual health. We offer a good training programme across a whole range of providers, whether that's staff who work in outreach services, youth services, housing services, school nurses, teachers, as a way of trying to raise awareness around sexual health. And in terms of the older generation, older young people, we run freshers' fairs at universities, and so those are all on at the moment, and they include sexual health. We run and manage a condom distribution scheme, and again, there's a lot of training and governance behind that, so opportunities for young people. Not necessarily, they may not wish to get condoms, but they may wish to talk to somebody about sexual health. So a whole variety of ways in which we're trying to raise awareness to empower and inform young people to make decisions over their own lives. Is there anything from a school's perspective?
I think you referenced the survey as well. So in terms of the results from the survey and the reduction in the awareness around sexual health services, it is something that we communicated to key stakeholders within schools and wider, so youth services, for example, just to ensure that the key messaging is around promoting what services are available to young people. And we're hoping that there may have been an increase in the next round of survey results, which will happen next year. But we do take those results very seriously and then look to make those improvements where they're highlighted. So hopefully there should be an improvement. And we know that the new public health nursing service specification, which includes our school-aged health service from school nursing, they've done a lot in terms of the promotion of their whole service, but including relationships and sexual education as well.
I think we'll sort of draw a line there because obviously this is now touching on the SHU report, which obviously is its own item as well. So thank you very much. I'm going to come to Anna now.
I'll be very rapid, Chair, thank you. I'm sorry for Becky again because I feel like you've talked a lot. But it's a really short one. You mentioned about the stock breastfeeding group, and apologies I was scrolling on my phone, but I just wanted to find the person's surname. Kim Crawford, say, Chew Valley resident. She's part of the group. She fed back to me quite recently that some of the restrictions in the fabulous children's centre now means that they won't allow older children to come in, and she thinks, and I agree with her, that would be a barrier for mothers that have multiple children. So as a point, could you pick that up, because I think that's really silly and that needs resolving. So I'm happy to work with you, but as you literally mentioned Radstock, I had to bring it up now. Thank you.
Thank you. I don't know if you needed to respond, Marcia, but I'm sure that's just a absolutely yes. Okay, so I had a few questions as well, but I'm just checking was anybody else in the panel wanted to speak at this point. Okay, so my questions are around obviously Newton House, and I hope that as well as what we are doing and all that engagement with the user group, whether or not there's some sort of learning from what happened that is being fed into future work. And then a similar sort of question really around the community support recommissioning work as well. And then you mentioned about the cool spaces and the 5 cool spaces. On the map that has been drawn up then, does it include these treed areas as well, or is it just simply buildings as opposed to sort of the whole broad spectrum of spaces that are cooler for residents? So I've got about 2 more questions. One is around chlamydia and gonorrhea. I just wondered why the focus was, well, it appears just from the report on women only. I mean, obviously these 2 diseases do affect men too, so I just wondered if that was just an omission or if there was some other specifics for that particular statement. And then finally, around the drug and alcohol services, I wondered how these services now are working with our, for example, street community, so groups that may not sort of show up as readily as others that that we are aware of. And then actually just one more point, and this is more of a request to make sure that the data on the summer half, can we make sure that that comes to our next meeting at of this panel, the one that's focused on children, please?
Okay, thank you, Chair. So the learning from Newton House, we've had 2 learning events, one with commissioners to learn from the experience and the feedback from the families. The families have been really very clear about what they expect to see and what they didn't expect to see. And the learning from that, we've also had a development session with Cabinet and Corporate Management team about the learning and the impact it had on families, and I fed that back to the families. So we're constantly learning and adapting. Around community services, we have a community services transformation strategy group where all of the feedback around the tendering of the community services is going through, because we feel it's really important to be able to work with both members and with the providers. I've had about 10 events with the providers, making sure before we went out into a tendering arrangement that we had the feedback from all of the providers, because that was where the learning was greatest. Of course, we had to then stop that once we went out to formal procurement, and before we advise of whoever has been successful with the formal procurements, I'll be working again with the provider services and preparing them for that. So there was a lot of learning over the last year on both those areas, and thank you for the question.
I suspect some of the other questions are for Becky.
Yes, that's fine. So the Cool Spaces map is specifically for outdoor areas, green spaces, where people can rest. It includes a lot of our parks, not all of our parks, and also other green spaces that are owned by other organisations. It includes also, highlighted on the map, are where there are toilets and cafes and seating areas. So it's really to try to find and highlight to people outdoor spaces where people can sit and rest when they're outdoors in green spaces, and then specifically those places that have got toilets and cafes and indoor spaces on them. I can send you the link if that would be useful. You can have a play around with it, and we will endeavour to build on that in future years, but it's fantastic to have, has been fantastic to have that over the summer. In terms of sexual health, there's been a recent review over the last few years on the National Chlamydia Screening Programme, and by and large, the main harm from chlamydia comes to the reproductive health of women under the age of 25. So the online testing service that we've recently commissioned with commissioners over in Bristol, North Somerset and South Gloss is our main way of implementing the National Chlamydia Screening Programme. It's open to women, that particular service is open to women rather than men, because the harm is much greater to women. If through that programme, the service will also do contact tracing, and so if as part of that service there are found to be male contacts, then they will always be followed up, whatever their age and whatever their gender, whether it's male or female contacts. So chlamydia screening and gonorrhea screening is available for men, and people will be encouraged to go to the Riverside Clinic, and anyone who asks for an STI test will automatically, proactively be offered chlamydia and gonorrhea, whatever their age or gender. So it is available, just not through this specific service. I hope that answers your question.
That's very helpful, thank you. Right.
And, sorry, Dini, you had one more question on drug and alcohol services, didn't you, and how they were working with the street community. So again, yeah.
Yes, apologies, I've missed that one. So yes, they do very much have an outreach team, and the outreach team works very collaboratively with housing services outreach team as well, because we know that housing and drug and alcohol use are so closely intertwined. So they are very much out and about, either outreach in different parts of Baines community, gathering a lot of that informal intelligence as well from clients and from people, as well as working through an outreach capacity with a lot of our different services across Bath and North East Somerset.
Thank you. Right. I'm not seeing any more people who want to ask questions on this paper, so we're going to move on now to the Baines, Swindon and Wiltshire Integrated Care Board update. Laura.
Thank you very much, Chair. I just have a handful of very brief updates, and then I'll hand over to my colleagues who will talk us through pharmacy. So if I may, as we know, there are several changes that are happening in the NHS at the moment, particularly organisationally, and the panel requested that I keep you updated of those changes as and when we can. So there are two very brief related updates to that. One is there is now an announcement of the new chair for BSW, for the cluster arrangement of BSW Somerset and Dorset. So that new chair will be Rob White. And also related to the ICB, the Chief Exec, Sue Harriman of Bain, Swindon and Wiltshire ICB, will now be moving on to a new role. She will be taking up the Chief Executive of Hampshire Hospital NHS Foundation Trust CEO role. So that means there will be a new CEO for the cluster to be announced. We are not able to announce that at this moment in time. So that's all that I had on the changes. We were asked a question around hospital passports and whether or not we might be rolling those out. As we know, we use them currently around the learning disability and autism cohort, and now also for some Gypsy and Traveller and boater communities, specifically with Eldan. It's not currently possible to provide everyone with a health passport. It's targeted at those individuals at greatest risk. And in particular, we think about things like frequent attendances, admissions to hospital, high-intensity user programme. So what we will be doing is working together when we co-design the future of neighbourhood health to take the learning from those health passports and see how we might be able to develop that further through that programme. So hopefully that's an update that the committee will welcome and find helpful. There's a very brief update around the Learning Disability and Autism new unit, the Kingfisher. Again, I think colleagues were very keen to understand the current position on that. I'm pleased to say that it is moving at pace and we expect it to be fully open in early 2026. I'm mindful that there were two questions that are not included in the report this time round. One was from Councillor Hardman around elective recovery, I think, and the HSJ article. I do have a response from colleagues. It is 2 pages in length, so I will email that across and we can have a future update on an agenda item if necessary. And the other one, I think we had some anecdotal feedback around RUH appointments. I've passed that through to our Deputy Chief Nurse, and we will be looking at some of the issues that were raised through our Quality Committee. So they're very brief updates, as I say, Chair. The core of the report is really around pharmacy, and my colleagues Helen and Victoria are here today to talk to that. But I'll pause just in case there's any questions on anything that I've said so far, Chair.
Thank you, Laura. So, panel, do you have any questions for what Laura has spoken of so far? Liz?
But not of what she's spoken on so far, so I'll leave it to the end. Okay, thanks.
No? Michael?
Well, I don't know if it's the appropriate time. I know we've already mentioned about the 10-year plan for NHS and its impact on rural areas. I know we've talked particularly around the services already, but I'm also interested in some of the wider implications of the 10-year plan on rural areas in particular, and what that means particularly around access to services, particularly if everything's going digital rather than analogue, and how that impacts particularly older people that may not have access to internet. It's been an issue I know that I've talked to lots of constituents, elderly constituents, that just feel very disenfranchised from the way the NHS is working at the moment. And though the 10-year plan sounds very grand, and the 3 kind of key themes I think are great. So, you know, if you're going to be taking services out from hospital into the community and into people's homes, can that be delivered properly and in an effective way? And also moving from kind of to the sort of third service area around just dealing with sickness to actually dealing with prevention, all those kind of things. I think that sound very commendable, but I just worry that rural communities, so much part of Baines is a rural area, is rural, that we're not going to have access to the kind of services that you might get in the centre of Bath or some of the bigger cities, bigger urban areas of the county. So for me, it's what is the ICB doing about that, to be kept informed about any new changes that are happening and to manage that.
Yeah, thank you for that well-articulated question, and I'm sorry to hear that you do have residents that say they're disenfranchised at this moment in time. So I think there's a lot in there, and if I may, around the 10-year plan, I think we should bring back a more formal update. We do have some information that I think you would find really helpful, some slides that I can circulate up front, and then perhaps we can have a discussion at a future panel. To the point about rural communities in particular, we have, as I said, co-commissioned integrated community-based care. From an ICB perspective, we are the lead strategic commissioner, but obviously we've co-commissioned with the local authority, in fact with 3 local authorities. Within that programme, there's a requirement for something called integrated neighbourhood teams. So the reason for that is to ensure that we have got that full coverage that you speak to, that we really understand our different communities and what their different needs are, and that we provide needs-led responses as opposed to services in silos that we expect people to come to. We think about how we respond to communities' needs. In the 10-year plan, there's something called neighbourhood health that's referred to. So quite clearly, what we've already commissioned as integrated neighbourhood teams is a core element of that. It won't be everything. We need to work alongside public health colleagues, as you've heard, around things like Wellbeing, and there'll be other wraparound services, working with BCSE colleagues, for example, as well. But those things together will come forward into what neighbourhood health will look like for rural communities. So we're doing a lot of work at the moment. Our lead community provider is working on what they call a discovery phase to really make sure they've understood the needs to inform that integrated neighbourhood team programme. And we're working jointly to make sure we get the best out of that, to make sure we deliver neighbourhood health. But I think if that's enough for now on that bit, we'll bring something forward. And you're quite right, in those 3 shifts in the 10-year plan, there's a lot to unpack. The analogue to digital, I think, is really interesting. It's digitally enabling and making the most out of digital, but not doing it in a way that's prohibitive for those that cannot access things digitally. So it is making it an option for those that can, i.e. them freeing up capacity for those that can't. So again, our lead community provider on the ICBC is really clear on this. They know that we need single points of access. They know that we need things like digital front doors. But that's not the only way for referrals, self-referrals and access to services. So I think that's really important for us to keep in mind. So thank you for raising that.
It makes you wonder whether or not there's a role for health in, advising perhaps on the broadband rollout. Leslie.
Thank you for the report, Laura. I've got various questions. So on the new cluster, which I think we said last time is absolutely huge, how will the new ICB cluster structure affect local decision making and responsiveness to community needs? On the pharmaceutical needs assessment, how is this being used to inform future commissioning decisions, especially in the underserved or rural areas? On the hospital passports, this is a really important initiative and really very welcome. How are the needs of other vulnerable groups, such as people with dementia or mental health conditions, being considered in similar circumstances? On the Kingfisher Mental Health Facility, how will this facility measure success in terms of patient experience, recovery, outcomes and accessibility? On the flu vaccination campaign, how is take-up being monitored across different demographic groups, and especially what about people who don't have access to digital facilities? And on the no, I lost that one. And can the ICB provide more granular data on service integration outcomes like reduced hospital admissions, improved patient satisfaction, etc.? Thank you.
Laura, do you want to park the one about the pharmaceutical needs, and maybe Victoria can pick that up, because I know you were doing like the second part. Okay, thank you.
Yes, thank you, Chair. That's helpful. And thank you for those questions, Councillor Mansell. If I take them in turn, on the new cluster arrangements, it does generate a large cluster. I think that is similar to the other clusters that we will then see across the South West. In terms of structure and how it will affect local decision making, the operating model of how that cluster will work is yet to be determined. So we are looking at that. If you remember, we have spoken before, there is something called an ICB blueprint that has been published. That sets out the expected functions that the ICB should now take. So primarily a strategic commissioning organisation, but with a number of functions that it's expected that we will be accountable for. What we are doing at cluster level is now trying to understand how we best deliver those functions, and to your point, Councillor Mansell, how we make sure that we still have those place-based elements, in particular in terms of governance, as part of that. So that hasn't been finalised, no decisions have been made, but obviously it is front and centre in people's thoughts as they look at that. And I will clearly keep you updated as we go along. The importance of health and wellbeing boards and scrutiny committees is well understood. So I think that's hopefully of some comfort to committee members. In terms of hospital passports and how are needs of other groups being considered, as I said, I think we're thinking about how could hospital passports lend itself to other cohorts of the population, particularly through that neighbourhood health work that I just spoke about. When we talk about those individuals around mental health or dementia, etc., I may defer to Suzanne for her knowledge here, but clearly when we're looking at the needs of different individuals, at times there may be things like Care Act assessments that we undertake or other interfaces that we have with individuals, and that's an opportunity to make sure that we are capturing what needs are and how we might respond to them. So I think what we're all trying to do as we work together is to focus on the individual so that they tell their story once, and so that we can appropriately capture information with their consent, and that we also support not just the individual but carers and family as well alongside that. So we use every opportunity, I guess, is what I'm trying to say in that space. In terms of flu vaccination, I believe we do have quite a lot of data around that. So I will ask colleagues, and I'm having confirmation nods from colleagues to my left here, so we'll ask colleagues on our vaccination team to come back with some information around the different demographic groups. And likewise, around granular data, around things like reduced hospital admissions, etc. We have something called an operating plan, and we do monitor that. And indeed, through winter, we also have local metrics that we measure. So, if I may, I'll have a think about what might be appropriate for the committee to see, and that might be links that are published somewhere else. So, for example, in the ICB Public Board, clearly they get that information quite regularly, but we might want to think about what in particular this panel would like to see as part of that. I apologise, Councillor Mansell, I think I may have missed one of your questions, not the pharmaceutical one, which we'll come on to, but I think you might have had another one, and I didn't scribble fast enough.
It was the mental health facility and how the success will be measured in terms of patient experience, recovery outcomes and accessibility.
Yeah, thank you. Yeah, I think it will be really important all through the design of that new unit. One of the things we're most proud of is that we've had the lived voice influencing that and making sure that it is a co-designed and co-commissioned service. That will continue to make sure that we get that feedback and make sure that we use that to improve the service on an ongoing basis. So that will be built into our plans.
Thank you.
Okay, so I have a few questions myself. So you mentioned, Laura, there's a blueprint for the future ICB. I don't think I've seen this. Is that possible to be circulated? And my apologies if you've already done so, and it's just, you know, I've not, it's not fixed in my mind. And then when we're talking about clustering, I think it's very telling. So we've got, you know, sort of perhaps sexual health service that is sort of kind of going quite sort of more sort of towards Bristol. We've got the Kingfisher, now again Bristol based, and yet our cluster is going more south and to the east, I suppose, which again feels, I don't know, maybe a bit illogical in terms of our population. And I know this came up at the Health and Wellbeing Board too. There is a sense that government wants the combined authority, the strategic authority, i.e. the mayoral-led authority, to be in charge of health and government strategy too. So is there any sense that the way that we're clustering or choosing to cluster is going to be unpicked at some point? And kind of then what would be the consequences if that is the case?
Yeah, thank you, Chair, for those questions. So on the model blueprint, yes, we can definitely share that. If I may, I'll give the caveat that quite a lot has moved on since that was published. So we waited some time for it, as I think members will be aware, and then when it came, subsequently there was a little bit of guidance and discussion around whether or not what was in the blueprint was correct, and there were national work streams, so things like SEND and CHC in particular, where it was queried that in the model blueprint it had been suggested that some of those functions might transfer out. It was recognised that would require legislation, and actually there's been a little bit of a rethink and a reframing of some of those issues. So I will certainly send it, and when I send it with the email, I'll make sure that the caveat is in there, but if members could just be mindful of that as they look at the blueprint. In terms of clustering, it's an interesting one, isn't it? Of course, there were different options that were looked at when we looked at clustering, and a lot of different things to take into account. And it was NHS Region and NHSE that had to sign off and be satisfied that the clusters, if you like, made sense. So it wasn't locally self-selecting, and as we all know, this obviously was a national direction, if you like. In terms of why the rationale for the clustering that we have arrived at, in terms of patient flows and in terms of how people access our health services, it makes sense to cluster on the footprint that we are on. I recognise that when we're looking at things like the West of England Combined Authority, that's on a different set of arrangements, isn't it? Travel to work areas and how one might plan housing and transport. So it is difficult. In the blueprint, when that was first published, there was a requirement to think about aligning with those mayoral combined authority boundaries. So they were looking for things to be conterminous, i.e. boundaries to match, because I think the idea was that would make most sense to local populations. However, when you then looked at an evidence-based approach, it just wasn't that clear-cut in the southwest. It's not quite so straightforward. So at the moment, what we're saying is that we have clustering arrangements. They are the arrangements that we need to work on moving forward in terms of how we look at the ICB construct. However, I think everybody is aware that there are different views around that, and that they will need to be considered when any formal merging arrangements start to progress. So at that stage, I think it's anticipated that there'll be another process to go through. I hope that helps a bit for now.
It does, and actually there was just one more question I had. I think you said that the new person would be Rob White, but I think in our papers it says Rob Whiteman, so I just wanted to know, is his name White or Whiteman?
Whiteman, I misspoke. Sorry, thank you, Chair.
Thank you. So now, Becky and then Victoria.
Thank you. If I may just come in just to make sure that there isn't an error in the minutes in relation to sexual health services. Just to be clear, the bulk of our sexual health services are commissioned by BAMES only, for BAMES residents. It's only one very small element, which is an important element, but financially a very small element, where we have gone in with BNSSG, and that's for the online gonorrhea and chlamydia testing. I just want to clarify that, and that's a very small amount, and we've done that for reasons of efficiency. We get an excellent service because it actually is being commissioned by a much larger set of organisations. Thank you.
Thank you, Becky, for that clarification. Victoria, would you like to now talk about the...
Yeah, I'm conscious of questions, so I won't take too much time on this. So really welcome the discussion and subsequent approval at Health and Wellbeing Board recently, led by Becky's team, Paul Scott. So really welcome the Health and Wellbeing Board's decision on that, and it is now the document that will be used within the Pharmaceutical Services Regulatory Committee to make future decisions for any new pharmacy applications or changes to any pharmacy arrangements as within the regulations that look after community pharmacy. That is the formal means to any changes. Really welcomed the discussion that Paul led on at Health and Wellbeing Board recently with regards to recognising that there are temporary closures across the county, as well as across the wider ICB, and also at a national level. So not being blind to those temporary closures. We had a discussion at Health and Wellbeing Board with regards to the terminology around temporary closures, and recognising that as the narrative within the regulations that we're presented with. Yeah, that is the document that we will be using going forward. I've brought my colleague here, Helen Wilkinson, to talk to some of the initiatives that are already ongoing within community pharmacy to build on future resilience and expansion, and our support from the ICB to community pharmacy, recognising, I suppose, some of the difficulties within community pharmacy, but to talk to some of the positive arrangements, if Chair, you'd like that.
Thank you. I am actually just going to jump in first, and then I'll bring Michael in as well. Could you just try and define temporary closures? Because obviously I know that the needs assessment defined it in a different way to perhaps how an ordinary member of the public might see it.
Yeah, thank you, Chair. It's a good question. So, temporary closures within the regulations essentially allow community pharmacy to close on a daily basis. Traditionally used for, I suppose, emergency procedures, fire, flood, etc. But has and does currently allow for workforce pressures. So if somebody is sick and the pharmacist is not able to attend the pharmacy, so that is on a daily basis, and obviously we do recognise that temporary closures across Baines in some areas have been ongoing temporary closures for a significant amount of time.
Thank you, Victoria. I don't know if your colleague wanted to speak before Michael comes in.
Hi everybody, I'm Helen Wilkinson. I'm the Community Pharmacy Integration Lead at the ICB. So my role is about implementing the new clinical services, things like Pharmacy First, blood pressure checks, the contraception service, and we've done quite a lot in the ICB around trying to do workforce development, because we've talked to you before about the workforce pressures that we particularly feel in BSW. So I'm happy to take questions, because I could talk for ages about this, so perhaps better to see what the team are interested in.
Thank you. Michael.
Mine's more sort of a general question initially. As someone who's relatively new, not knowing too much how pharmacies should work in practical terms, and obviously looking at your report talking about the state that the groups exist around geographical location of pharmacies, provision of services geographically, and also the timing. What I'm interested in is, do you have, when a pharmacy is either up and running or being considered, do you look at it from a population number point of view? Because I'm thinking, as a ward councillor for Midsummer Norton, Norton has what's over nearly 12,500 population, and we have 2 pharmacies currently operating in Midsummer Norton. We lost one, and then I look at the other areas in the Somer Valley, the Radstock population of just over 6,000 with 2 pharmacies. Westfield's got just under 6,000 population with just 1 pharmacy, and Porton just over 5,000 with 1 pharmacy. And this seems to be, for a population of that size, particularly the higher number of older people that probably live in those areas that will rely on the pharmacies for picking up their prescriptions. Is any consideration taken into population numbers when you're considering where to locate and a pharmacy, and then also as pharmacists are taking on more of the pressure from GP surgeries in terms of some of the other services that they're offering, that also puts more pressure on the staff that are working in those pharmacies to deliver those services. So I didn't know whether in terms of the, there's probably quite a lot of issues there, we've covered those questions, I do apologise, but in terms of the needs assessment, are all those kind of things considered? And obviously I'm looking at it from an impact in my own ward and the Somer Valley area in particular, and I guess it also runs into this bigger question about rural healthcare and how pharmacies are delivering in the rural areas as much as they are in the more built-up areas.
Thank you for the question. So I'll start with the application process and that decision as to where to locate a pharmacy, and I'll look to my colleague to pick up on the clinical services developments. So it's really interesting with community pharmacy in that whilst as public health have led on the P&A, the pharmaceutical needs assessment, that determines, I suppose, the need of community pharmacy across Baines, and we've taken a really interesting approach this year, working with the public health team to introduce more and not duplicate with the joint strategic needs assessment, but to introduce more of those demographic factors within it to allow an understanding of the clinical services that may be needed within areas. So it's a nod to understanding those population needs, which sounds quite simple, but is actually a real step forward for the P&A, and not stepping outside of the legislative scope of the P&A. With regards to the application process, that is not led by the ICB or the NHS or the authority or the public health. That is led by individual community pharmacy. There are several different types of application that a community pharmacy may apply for, with regards to improvement, unforeseen benefits. So the onus is on the applicant to demonstrate to the Pharmaceutical Services Regulatory Committee of the need or the improvement or the different type of application that they're using to evidence and address the question, I suppose, within the application. So how they will improve services, or what is the unforeseen need that they are now addressing to tackle community pharmacy access, or what services will they be delivering to address the need within the area. So it's slightly different really than GP services or dental services. Yeah, shall I pass on to you for the clinical services?
Yeah, so if I talk a little bit about, I think your question was mainly about workforce and the team in the pharmacy, wasn't it? So yes, absolutely, there's a change that's been happening within pharmacies and a need to free up pharmacists away from the dispensing process so that they can focus on the clinical services and use their skills to best effect. So the ICB has done quite a lot around pharmacy workforce. We have just this year implemented a single trainee employer model. So BSW had a few years ago had a 25% vacancy rate, and I'm sorry, I don't have a Baines specific figure, it just isn't available to us. And we came to present, I think, probably a year ago. Yeah, might have been two. So we knew we had a real workforce challenge in our pharmacist population in BSW. We've done a lot to try and rectify that. We've worked really closely with the university. We've got a single employer model, so whether you come to do your training year, so as a pharmacist you do your 4 years at university and then a 5th trainee pharmacist year before you sit your exams to go onto the register. And we've now got a model in this area, whether you go to a hospital or a GP or a community pharmacy, you're employed by the same organisation, actually a community pharmacy in Wiltshire. And that means that we can give a much more attractive offer in terms of salary, in terms of conditions, to hopefully bring pharmacy students into the area. So we're doing a lot around the single trainee model. We've done a lot around the Inclusive Pharmacy Practice Manifesto. We've done quite a lot around pharmacy technician training as well, to bring a different skill mix into the pharmacy. There's some legislative changes happening nationally around workforce. I won't get into the technical details, but around how supervision works in the pharmacy, around the dispensing process and who can be responsible for that. Things like hub and spoke dispensing to again look at how we do things differently. And there's a lot happening in the digital space around use of AI and technology to support with some of those processes. So you're absolutely right. Pharmacies are having to look about how they use their teams slightly differently in the future. And also doing quite a bit, like you say, around the education and training to make sure that people are comfortable and upskilled to deliver pharmacy first in contraception and hypertension. Did that answer your question? But sort of. It's a work in progress, but absolutely a priority to look after the workforce.
It's kind of more about the planning and how it services the communities that they're in. And I think also if we look at the census numbers from 2011 to 2021, the percentage of older people in Baines has gone up, and they're now forecasting another significant increase before the next census. So we know that we are living in a county of older and growing older population, and what impact that will have on all our health services, not just pharmacies, but all our health services. And I'm sure that's been taken into consideration, but in an area like the Soma Valley, we have a high population of older people that need to be serviced properly and not disenfranchised from the service they need.
Sorry, thank you. I don't believe there's a sort of a definitive number of you should have X number of pharmacies per population. I don't think that exists nationally. And like Victoria is saying, even if there was a gap identified, it still requires a contractor to want to come in and think they can put a business in that area that would be profitable and self-sustaining.
So I've got... Sorry? Yes, David. Yes. Sorry, yes, David.
Thank you, Chair. Sorry, my question is related but not specific to what you've all kindly presented today. It's regarding pharmacy access and digital and rural health issues, because GP dispensaries are excluded from the NHS app and prescribing technology because they're not funded. So it places the rural GP dispensing pharmacy at a disadvantage because it requires the GPs to pay for the IT support rather than what's happened to commercial pharmacies where they've got money. So there's the potential for an increase in the digital divide out in the rural communities and threaten to GP dispensing in their own pharmacies. So I'm just wondering if this will be being looked at in the round to see if we can get greater support for the pharmacies so that the rural communities can use the app properly.
Yeah, I think we'll need to take that away, David, and look at that. But I think I will make a point that we are obviously supportive of dispensing in rural areas and recognise that to certain populations their dispensing GP is crucial.
Thank you.
We'd be grateful if you could send us the information that you have. That would help us follow that up.
Sure.
Thank you ever so much.
Leslie. Yes, just to be clear, there's only one pharmacy in Radstock. If you need the pharmacy on a Saturday, it's closed. And I'm not sure whether that's temporary or whether that's permanent, because it's been closed for quite some time now. However, you could go to Midsummer Norton, where the pharmacy is open on a Saturday. The Radstock one is open from 9 till 5. The one next to the GP surgery in Midsummer Norton is open 9 till 6. If you are in Ruthlington and you don't have access to any kind of transport, then on a Saturday you would have to somehow walk from a mile down a hill into Radstock, and then you can get a bus across to Midsummer Norton and back at certain times of the day. A
can't remember what the exact figure is. It's somewhere around 60% of people actually work outside of Radstock. So if you're working outside and you don't get back before 5 o'clock to go use the pharmacy in Radstock, then you'll have to get across to Midsummer Norton to get in there before 6 o'clock. And that is probably not possible for a lot of people. So we've had this discussion before about access. So with this P&A, what specific gaps have been identified and how are they being addressed? And go to my previous question, how is this being used to inform, how is the P&A being used to inform future commissioning decisions, especially in the underserved or rural areas? Thank you.
Thank you, Councillor. So just a point of clarity, there wasn't any gaps identified within the P&A. Individuals and the public do have access to online pharmacies who deliver directly to home. There are national companies as well as local companies who will deliver directly to the door, and we acknowledge for the working population who may not be able to access community pharmacy within those hours, that may be a more suitable arrangement for individuals. Was there anything else? So with regards to the P&A and its use, I think I probably have already covered that there's currently no gaps that have been identified. However, that does not stop any community pharmacy making an application for unforeseen benefits. That will still be assessed with what is contained within that application. And to understand the evidence that they're using to describe any unforeseen benefits. So again, the onus will be on applicants to make that application to the committee.
Thank you. Just checking, Anna, did you also have a question you want to ask? Or?
No, David did it.
That's good. David, do you want to turn your microphone off?
Sorry.
Okay, so I have a question then, which is around, I think we're all acutely aware that there is a shortage in the numbers of dentists, of GPs, of pharmacy staff, and I just really wondered, where does this stem from? Are not enough people choosing to go and do those courses? Is there more work that could be done in encouraging that? Is there a artificial, barrier to the numbers that can take up those courses? Where is the problem?
I think there's been a few things. I think in terms of attracting people into doing pharmacy as a degree, we're doing a lot with schools and colleges to promote it as a profession. Bath University's just opened a second site down in Plymouth. The southwest, I think, has always had a tougher workforce problem in other bits of the country. So I think we're getting people coming into the degree. I think once you qualify, you've got a choice. You can go into community pharmacy, into hospital, into general practice, a few other industry, a few other places as well. I think community pharmacy has been less attractive in recent years to bring people in. You've got weekend working. You are quite often the sole pharmacist there, so it could potentially feel a little bit more isolated. Traditionally, it's been seen as a place that's less clinical in terms of the skills you could use, and so other sectors like general practice and hospital have attracted people. They could offer prescribing qualifications and those sorts of things. So I think now we've got new clinical services coming through in community pharmacy, and from 2026, any newly qualified pharmacist will go onto the register as a prescriber. There's a real opportunity for us to make better use of those skills in all our community settings. Our community pharmacies are in our neighbourhoods, aren't they? So I think it will hopefully change over the next few years, but it's probably been seen as a slightly less attractive place to work in recent years, and we're doing our best to change that.
I'll also add, Chair, Helen's probably been slightly coy about the single employer model that she's previously described, and the level of opportunity that does actually provide to share out those training pharmacies within community pharmacy. Last week was up, Helen Hunt and her team were up for a national award with regards to that model. So, yeah, it is a real step forward for distributing those individuals.
Well, congratulations on your nomination. I also just wondered, so, and Michael touched on this, so we've got a growing older population. So are we only looking at younger people, you know, the sort of traditional types who will be going to university? I mean, is there anything being done to perhaps attract those that might be looking for, you know, career change or just, yeah, older, looking to do something different, maybe having done very different jobs in the past?
I think that's an excellent idea and something we should explore. I don't think we've done that yet, but certainly no reason why we shouldn't. I think we're also not just looking at the university and that route for the pharmacist. It's about the whole team in the pharmacy. You know, your healthcare assistant, your dispensing assistant, your pharmacy technician, and actually those are not all roles that need a degree, and it's really important that we get a mix of different people from different backgrounds. So I think we're trying to look at it as a whole, but the initial work has been about the immediate pipeline that we needed of pharmacists.
Well, that's great, thank you. Any more questions from the panel on this paper? Liz, did you have some questions?
Thank you, and thank you very much for that discussion. Actually, it raised a huge number of issues, and I think we're looking at them, so it's good. I'm going back to the transfer of services to HCRG. So, Laura, I think this is probably one for you. And I have been made aware of very big concerns that there's been no proper transfer plan from ADHD and autism, these services, which were the only BAME services not run by HCRG. And I've got 4 questions, really, to ask about this. The new service for ADHD is monitoring those already on medication and will soon start to see those with a diagnosis who might benefit from medication. But there's no waiting list for those awaiting a diagnosis. So is this correct? The ICB also wrote to 5,000 patients who had been on the list, asking them to confirm they still wanted an assessment. 2,000 responded, but the ICB have yet to send a follow-up letter following this up, so they've just been left. So is this correct? Third question, proposed costings as to which services HCRG were responsible for example, ADHD and autism. The proposed costings were lower, much lower than the consortium's bid, and they now have to make savings from other parts of the budget to pay staff they are responsible for. So this has been brought to my notice, and is this correct? And finally, I believe I've asked this before, but do we have processes to monitor and measure the performance of HCRG, plus what indicators are being used and what patient concerns are looked at as well? So 4 questions, Laura, thank you.
Thank you, Councillor, for those questions. We gave an update, actually, to the Wiltshire HOSC recently, and if I may, I suggest that we forward that to committee members, because I think that would be helpful, and indeed we can come back and give a more fuller update, and I'll take those questions away and do a written response. But just very briefly, answering each one in turn. So the transfer of services from AWP to HCRG, as we know, that took effect from 1st of April. And as we also know, as strategic commissioners, we made the decision before the transfer of those services to make sure that we had understood fully those that were waiting on the waiting list. So did they know they were waiting on the waiting list? Did they know what they were waiting for? And did they know what options were available to them? I think it's fair to say that it's not unique to BSW, but certainly nationally, we know that there are significant wait times. And in BSW, it could be up to as much as 8 years with our previous provider. So as you can see, that was quite significant. So hence, we took the proactive decision as strategic commissioners to write to everybody, as you say, on that list. And what we wrote to them with is making sure that they were aware of the choices that were available to them. So, for example, that you do not need a diagnosis in order to have things like reasonable adjustments, either in your workplace or in college. If that is what you were waiting for, there would be alternative services that could support you in that. If you needed medication, if you wanted to remain on the waiting list, and then also something called right to choose. So if you wanted to remain on the waiting list, but recognising that there are significant wait times, there is something called a right to choose policy, which enables people to choose an alternative provider. Now, these providers are ones that obviously are accredited and known to us, and so I know that there have been problems in the past where people feel that if they get a private assessment, it's then not recognised. So not that. Right to choose providers. So making people aware of the choices that were available to them. Of those that responded and requested to remain on the waiting list, they are indeed on the waiting list, so there is one that exists. And we will be writing out to each of those, and they are being progressed through with our new community provider. Our new community provider who accompanied us, HCRG, to the Wiltshire Scrutiny Committee, made it very clear to that committee that they have obviously undertaken recruitment and got professionals in place to be targeting the needs of the people on that list. And one of the crucial things that we're working collectively together on is how we support people to wait well. Now, that's not just unique to this particular waiting list, but all waiting lists. So what other services can we do in the meantime? Of those that are currently receiving medication, I think it's in the order of around 600, and I can confirm that they are, of course, still receiving that medication and still having their needs met. And I think in addition to that, there were 50 that we had identified needed to be expedited quite quickly, and they were a combination of different reasons, also looking at things like armed services and so on. So I hope that helps provide some assurance around what process we followed. We did brief people before we were doing that, and we did also take that through our governance of the ICB board. In terms of the measures to monitor progress, that does come through that community-based contract, and as you might expect, I'm the executive with lead for learning disabilities and autism, so I'm also very keen to make sure that we have that information and monitor that, and we can bring that back if that would be helpful. The third question, Councillor Hardman, around the proposed costings being much lower than the consortium bid, I don't recognise that, and obviously I'm mindful that that obviously is a commercial sensitivity potentially in terms of that other consortium bid. What I can confirm is that we have made provision, so there was no reduction in cost in terms of what we put forward into that commissioning, and as we know, we have seen significant improvements for some service users, particularly for children and young people, from HCRG, from the community provider, and we've had really positive feedback, particularly from those young individuals and their parents and carers. So I can certainly look into that, but obviously I'll need to do that in a proportionate and appropriate way. But if you give me the information that you have, let me look at that more fully.
Many thanks indeed. Thank you.
Okay, so Leslie, and then I've got some more questions.
Yeah, thanks for that. Can I just ask, you just stated that people don't need a diagnosis for reasonable adjustments. My experience in the hospital trust is that for neurodivergent staff, they have to go through 9 hedges and jump through several hoops because managers are demanding that there is an official assessment. They're usually sent through a whole circle of going to occupational health, coming back, getting frustrated, going off sick, which costs us money while they're off sick, and somebody's got to backfill in a service that's already short of staff in the first place. So have hospital trusts been informed that people don't need an official diagnosis, bearing in mind that going to a private provider can be expensive? And what kind of support is in place to ensure that staff can get the reasonable adjustments they need in a timely fashion? Because access to work now is taking 6 months sometimes, so it's not that simple. And there's been some recent cases at Employment Tribunal where huge amounts are being paid out to people because reasonable adjustments have not been made because of the neurodivergence. I'm talking about in the health sector, I'm not talking about anywhere else. I don't know what the other figures are, but I know that they're increasing in the health sector. Thank you.
Yeah, thank you for that question, Councillor Mansell, and I share your disappointment. Reasonable adjustments are, or should be, available to all. So it's disappointing to hear that there are demands for formal assessment. I think, again, as I say, the intention is to make people aware of their rights and what they can ask for. So there is signposting to information on that and people that they can talk to for advice. That's what I mean about supporting the waiting well. In terms of any specific examples that you've got, please do feel free to share those with us and we can follow that up more fully. But I do recognise what you're saying. Clearly we're reliant here, aren't we, on those individual employers to actually be taking accountability and making sure that they provide reasonable adjustments. And I can understand that that might be variable in people's experience. So yeah, if you want to send us any further specific information. But in terms of how we're supporting people, we're making sure that we give them access to information about what reasonable adjustments people can ask for.
Thank you. So I'm just going to take us on a slightly different track, which is around the RUH. And I think many of us will have been very disappointed to see its ranking as 112 out of 134 hospital trusts. And I think it also feels, I mean, my own experience of the RUH, I think mirrors many here, which is it's always been exemplary. So I just wondered whether or not you had anything that you could add around some of the areas of concern that were found, particularly around staffing and care, and also the facilities and equipment and safety, and the monitoring of those. And I think there was also something, I think the staffing and care, I think particularly referred to the emergency, sorry, in my mind it's always A&E, and I can't remember what the D stands for now, but oh, just department, yes, of course, thank you. Yes, so it'd just be, I think, useful for this panel to hear comments that you have on that ranking.
Yeah, I think it's fair to say that, obviously, as we know, they're sort of composite scores and ranking, and therefore it's obviously clearly relative. What I would prefer to do, if that's okay, Chair, I think if we give our RUH colleagues the opportunity to actually give a formal response to that, because I think that there are some areas where they can provide assurance, certainly to this committee. And I think you're right. What we see in those league tables, and this is inevitable, isn't it, with any league table, you're going to get some variances within it. They don't always match the experience of people day to day. And I'm pleased to say that we don't recognise necessarily that low ranking in terms of the experience that our residents and communities are having, thankfully. So I think if I may, Chair, I'll take that one away so I can do a more formal answer, because obviously that's quite important and sensitive, I think, with colleagues.
Laura, I think we'd appreciate that, and then perhaps we might have an item on not our immediate next meeting, but the next one that's on adult social care to explore that more fully, and obviously would be good if we could invite and expect the presence of RUH colleagues. Thank you. Suzanne, was that what you were going to offer?
Yes, that's what I was going to suggest. I think that we haven't had operational RUH colleagues here for quite some time, probably over a year. And there's a new managing director there, and I think we should invite him, and it would be a good opportunity to do that. What I would say is that from Bain's point of view, those patients coming through the system are generally having a good experience. They're not staying too long in hospital. They're moving through the system very quickly. But I'd like to show the evidence of that maybe in November.
Thank you. Right. Now we move on to... Sorry, Joanna.
Thank you for all the reports. Can I just ask for the next update, for there to be something on vaccinations and what's happening in the changes to vaccinations, and also the present discussion within the wider community about whether you should or shouldn't have vaccinations?
Yeah, I can perhaps if I follow up with you offline and make sure that I get the nature of the question correct. Yeah, we'll take that away and we'll bring that back in the next update.
Thank you, and that has reminded me of another area I wanted to have an update on, which is specifically around COVID, because I think there is always that sense that it's gone away, but we know that it hasn't. It's very much present, so I think we should have an opportunity to explore that, both in terms of the vaccination programme and the changes to that, but also the impacts of long COVID as well. Okay, thank you. Right, any more questions on this paper? Then I'm going to move on to item 10, which is the CQC Action Plan update. So I'll invite Alison to update us on anything further to what's in the report.
Yes, thank you. Yes, this paper brings us up to date with where we are with our improvement plan following the CQC inspection. There's been a huge amount of work going on. We've invested additional resources into supporting the work, and there's a structured programme for delivery. We're working on 9 priorities with 15 different work programmes, and I'm really pleased to report that we are making very tangible progress. It's set out in some detail, so I think probably it's best if I don't go through it in detail, but we are available to respond to any questions or points of clarification that anyone has. Thank you.
Thank you, Alison. So I turn to my panel. Liz is first.
Thank you. Well, there are lots of positive things here, and Suzanne promised us that there would be an ASC improvement board, and it has been set up, and it looks like you are meeting very regularly, so it's good to see the feedback. Also, the 4 themes look very comprehensive, with the 9 kind of points that will be covered. But when I went back to the April report, which is when the CQC assessment and the publication of their report highlighted quite a number of areas, some of these were that carers said they were in the caring role for some time before being offered a carer's assessment, and they didn't know what impact a carer's assessment would have. The local authority identified the need to improve the carer's offer. So do you think, it's theme 1, which is how the local authority works with people, do you think the public will have access to enough information, advice, guidance to enhance the provision that they're getting? And there's also one area of to improve the provision to unpaid carers who didn't know what help and support was available. So it's just asking you to reassure us, do you think theme 1, which was an area highlighted by the CQC publication of its report and its assessment of BAMES, do you think these will be met within theme 1?
Thank you, Councillor Haddon, for the question. Yes, I do believe that the work we've done, particularly with carers and the Carers Centre, and the number of assessments that we have done for carers has increased. What we have been doing is the advice and information guidance. We've actually done a load of work with the Carers Centre about how that looks like. We're in the process of doing a survey with Health Watch, just checking out, is that right? Is that your experience? Are you getting enough information? Are we giving you enough of a prevention offer? What else do you need? And one of the big things that's come back from some carers has been around, it wasn't clear, the assessment, whether they could have it in the carers centre or they could have it with a social worker. Now that process is quite clear. So it'll be interesting to see the feedback that comes from the survey, which will probably go out next month from Health Watch. I'd be really keen, probably by the time we get all the feedback, it'll be January next year, to bring that back as further evidence of the work that we're doing and what carers are telling us, but not just carers, because we're also doing it for people who use the service.
Thank you. And I did note you put in the numbers that have reduced occupational therapy, waiting times, things like that, which is really good to see, which we've raised here you know, for half of our panel to say that we really are concerned about those. You do mention co-production. Could you explain what you mean by that? Thanks.
So co-production is all about the work we're doing with people who use the services and carers and how we improve the offer. So it's about designing the services with people, for people. So a good example of that is Newton. The other example is the work that we're doing with the Carers Centre and the work we're doing with Health Watch. We've just sent out, from a co-production point of view, we've sent out a survey about how people want to further work with us. So it's every layer. In our new system around Care Act assessments, our staff ring back and check, what was your experience of that assessment? Was that good? Was that a great experience? Where can we learn from it? So just checking out, helping to constantly redesign and improve the services. The OT Assessment Centre, which Councillor Bourne and I went to visit about a month ago now, straight away you go in, you have your assessment, your piece of equipment that you need to use with your family member or without your family member or with your social worker. And straight away you give feedback then to the assessment centre. This was a good experience. Actually, you weren't very good at this. I'd have rather have that. So it's layers of co-production and planning. And one of the things that CQC said about us was that people's experience wasn't as good as it could be. So that's why we're trying to work across all age groups, including young people, because we commission young people services as well. So we're trying to get the feedback from all age. And we're constantly trying to find different ways of doing that.
Thank you. And I know what co-production is. Thank you.
Jess.
Thank you. Thank you for the update. It's really reassuring and good to hear some of the examples of how people's experience of services will improve. My question was just about the timing of the next assessment. When do you expect the CQC to return?
It's hard to say because at the moment they have 153 they had to do to get a baseline. They have actually now, all councils have had their dates, but not been assessed. Just to say, our assessment was last April 24, and we had just taken back HCRG on the 1st, and CQC started that process on the 10th of April, which, you know, we weren't ready for, but it was free assessment. So I think what will happen next will be, we're more likely to have an inspection probably after the summer, in 2026. That's what I think, but it's hard to know, and they are changing the framework as well. So they're working through, and they're working through with us on that. So some of the things, you know, I've talked about Care Act assessments and people waiting. So I've talked about the numbers today is further down to 60 now because it moves all the time. 40% of those will already be started the assessment. But actually the methodology from CQC is that unless you're finished the assessment, you're counted as waiting for an assessment. So things like that they're thinking about changing. They want a bigger focus on people's experience, and they want to theme some of the assessments as well, a bit like Ofsted. And they're talking about an opportunity to do a review and an assessment in a, you know, more themed rather than in the general assessment that they've done now. And what I would say is I've seen the assessments they've done with other councils, and actually they're becoming much more streamlined, much more skilled than they were. We were one of the first 5 nationally to be assessed, and all new inspectors in place as well.
Leslie.
Yes, thank you for the report. I think I've said this before. We don't necessarily understand the amount of work that goes into something like this. It's a huge piece of work, and I think we need to recognise that. The question for me is around how will you ensure there's a level playing field for service users to have meaningful input into this design and co-production of services. If we look at the Care Act 2014, it talks about 7 duties. One is to provide information and advice to service users. How will this be met? and how can they have an impact. I have looked at the equality impact assessment. Now, is it correct that it's just focusing on who's implementing the improvement plan? Because it doesn't seem to mention very much about the service users. Is there a separate equality information assessment for that? Sorry, impact assessment for that, or is that to be added later on? Thank you.
Thank you, Councillor Mantle, for those questions. Ensuring that there's a level playing field, for all age groups. That's, I think I've probably answered that question already. We're working across all the age groups, whether it's from 16 up to working age adults and older people, to ensure that we have all of the voices. And there's different channels and techniques, whether it's technology or it's in writing or it's surveys or it's talking to people, it's our complaints, bringing all that together. The providing information and advice for all of our residents and the prevention offer. So we have Live Wellbeings, which is a really good offer you might have seen already. We also have our Community Wellbeing Hub, which gives lots of information and advice, and a prevention offer as well. And that, Community Wellbeing Hub has been recognised as exemplary across the system. So that's where a lot of the information across for all age groups goes. The EQIA, we really struggled with this because we first of all did an EQIA which was for the residents, and we thought that was the right thing to do. And the advice from our EQIA coordinator was that we need to do it for the staff that was implementing it. I think we still will need to do another one for our residents, but we haven't done that as of yet. We have it ready. And I think we've got more work to do on it because the advice from our coordinator was to do it in this way first. It's a very good point, and thank you.
Can I just come back to Susan? Yes, you did answer about going across different age groups, but what about different communities? Because different communities have a different understanding of terminology like carers, etc., and even disability. So the Somali community, for example, doesn't have a word for disability. So how are you going to ensure that service redesigns don't unintentionally exclude people with different protected characteristics?
I think because of the way that we're structured as well in our new structure, we very much are focusing on some of the rural communities, some of the different groups with protected characteristics. And because if you think about I'm going to say around our Midsummer Norton team, so we have a dedicated team out there, and their needs are quite different from the Bath team. So that's the way it's picked up. Some of the work around the hospital teams will be different from the long-term teams. We're constantly doing different things around the needs of different protected characteristics. And I think probably in an EQIA for residents, we would probably have to demonstrate that as we work through this improvement plan.
Thank you, Suzanne. Joanna.
Thank you for the report. I'm looking at Section 5, resource implications. I just wondered, if you wanted to talk a little bit more about 5.1 and 5.2, and also as we as a committee certainly take a view on budgets, is the amount that you've got enough, and should we be pushing for more?
An issue actually. So we've been very lucky in that I hold a contingency for adult social care, and that contingency, Alison and I, with the support of the 151 officer, agreed that we would utilise. So we utilise that for extra OTs, the new OT assessment centre, and extra staff that we've got in place. That's a one-off money. That's just a one-off money that we're using for that. What will happen if we don't redesign and restructure that we've just actually restructured, and that will be implemented in 1st of October, that we won't be able to continue to have those extra staff if we don't use our technology in the way that we should. So, for instance, we've got new technology for social workers, so it's called Magic Notes. So if I go to your house and I do an assessment, I do it on the phone, and then everything loads up onto the assessment, then I'm able to share it there and then with the family, whereas before that would have taken quite a lot of our resources. So technology is really important, but also making sure we have enough qualified social workers, and actually we don't hold very much agency. We've got enough social workers and OTs to do the job. I, this year, requested from Cabinet overall about 5 million investment, and we've had that 5 million investment. Now, for next year, we're working through that, and I'm expecting to put the increased need across the service, and I expect to receive that. Obviously, there'll be savings up against that. It's a balancing act. What we've seen, our biggest pressures right now is in LD, learning disability services, and in older people, because we're seeing the growth of those two areas. Trying to manage that within the budget we have is, I'm not going to say is easy, but we'll break even this year, and I hope that next year for 26-27 with the investment from the council that we will also break even, but it's really tough.
So we've heard from various councillors today saying how Baines has got an older community and it is getting older. So how should we as a council focus on that?
Their aspirations are also better. So there's an expectation when they come in from children's services into adults that there's the work that we're doing. So I suppose the big example I would give about that is we've got two projects which are in place now for people with learning disabilities, which is Sully and Hickeys, and I'm really excited about some of the work that we're doing around English Plume Lane as well. That's 16 units there, bungalows, and so that's to manage the demand. We're constantly thinking about the future and how the council can support us with that. But we've got to move forward all the time.
So one of the issues that came up at our recent corporate parenting was that care leavers are one of the services of housing is where we're not very good at providing them with the appropriate housing once they get to 18 to 20 to 5. So I guess how do you incorporate that into the work you're doing?
It's a good question, but we don't take on all care leavers. It'll only be people who, under a Care Act assessment, will get accepted as adult social care. Housing is an issue for for those care leavers, not particularly for the people that we accept, because then we have, under the Care Act, we have a responsibility to work with housing to make sure we have the appropriate housing for them. I sit on a housing panel working through that.
Chair, can I just raise a point that the other climate emergency has housing on its, and with the local plan, there seems to be a lack of consideration about this issue and how we discuss it. So, for instance, at corporate parenting, we clearly heard about the issue of young people and not having places to live. Yet we're hearing that in this setting. They aren't hearing that in the climate emergency, yet they're the ones discussing housing and the local plan. So I just wonder how we bring that together through the two different committees.
Part of that, I think, will be from the communication between the various cabinet members, but also as the chair of this panel, I also chair a meeting of the other panel, so I can certainly bring that up as an issue to the chair of the climate emergency panel. Okay.
I think it's a really important thing that we get right at this point.
Can I just add a little bit more in response to your questions, Joe? Firstly, in relation to the investment and whether it's going to be enough and if it's going to be enough going forward, and we're very aware that this is short-term funding to address some of the issues and to give us the capacity to allow us to remodel the services, and we will be very carefully monitoring the impact of that. But our our plan is that by having this upfront money, we will be able to make the changes to the service that we need, that they will be able to manage the capacity going forward. And obviously, as Suzanne says, we look at that on an annual basis when we set the budget as well. So it is reviewed on an ongoing basis. But I do think that the upfront investment should make a real difference, and I think it is making a real difference, which is great. And just in relation to the question you raised about our ageing population and how we're managing that, I think the other thing to say is that the work we're doing on age-friendly communities is also part of that, through making our communities more supportive to people as they age. That has a preventative function, so we will hopefully be delaying the number of people coming through to adult social care, delaying the time they come in to adult social care by providing a broad range of preventative services to help them stay well and functioning for longer.
Thank you. So I have a few questions that I wanted to ask. One, I think, follows on from the point that Joanna was making about savings, and I guess it's that reliance on bodies that will be maybe being changed because of those the cuts to funding from the council, you know, as we move forward with the budget. And I wondered if you'd identified any of those bodies you know, as being at risk in terms of delivering the you know, helping deliver that improvement plan. And aligned to that is obviously the role of Health Watch that you've referred to a couple of times, and we are aware that at some point they may disappear. You know, whether or not their role is taken on by another body, how that is formed, you know, is not known. So that was one question. Then I had another question which is around equality, and I'm very glad that you said the piece that you did about that we need to do an EQIA for residents, because I think some of the EQIA commentary might feel a bit unhelpful. So, you know, when we're looking at, for example, sex, and we've got staff involved in the plan are men and women, you know, for example, or age, you know, the staff are diversely aged. It feels that that's not super helpful in terms of making sure that those protected characteristics are needs are met. And then there was another point. I was trying to find the piece in the papers, but there was certainly something that identified the greater proportion of our local population as being predominantly white, but then there was nothing to say about those that are not. So it felt a little bit like we'd kind of gone back to that old grouping where we put everyone who's not white in the black or the BME category. And again, I wasn't sure that that was as useful as it could have been. And then final points are around that engagement with residents. I think in the report it says the resident survey is, or was at the time of writing the report, with the ethics panel. So I don't know if that's now come back and if there's any feedback you want to give on that. And then lastly, you know, we talk about pathways, we talk about dashboards, etc. And I just wanted to be assured that these are actually easy for residents, those that are not the kind of like experts in how councils work, that they're easy to access and to navigate, and actually to navigate and get something meaningful from.
I think one of our biggest risks at the moment is Health Watch, and I don't know how that's going to work through. We have a contract with Health Watch, so I assume that continues on, our local Health Watch, and we're working with them. And we'll need to work through that over the next number of months, whatever happens with National Health Watch. So that is a risk for us. I think the other risk really is about being able to deliver all of the changes that are required to improve the service. I think we've got enough now. Whether we'll have enough longer term to keep this resilient is always a concern. And it is on our risk register. The issue about equalities, as I said to Councillor Mansell, the advice was to do it around the improvement plan and the staffing. But from what I've heard here today, we will need to come back probably after Christmas when we do the January update with an EQIA for the residents and the effect of the residents. I think it makes sense. Around our data, we have got a dashboard, and that's all internal, but for the residents, what we're doing is self-assessment. So what we want to be able to do is do 2 or 3 pages of an update to all of the people who use adult social care, with the amount of people we see, all quite visual, the waiting times, the advice and information. Just do 2 or 3, and we're working on 2 or 3 pages just to keep people updated on the improvements and what else we need to do with some data as well. So I can also bring that back in January, because it will be ready and probably out by then.
So you were nodding about the resident survey and the ethics panel?
We've gone through the ethics and it's been accepted. I think it was quite a hard process to get it through and make sure that we're doing everything right. So yeah, it's ready to go now. I've just had it sent back to me this morning.
It's very timely then, isn't it? And then one more question, which actually is about our equality duty, and we talk a bit about training, and we have mandatory training for staff. I will leave the point about maybe for councillors out for now, but I just wondered how often that mandatory training is given. Is it repeated? Is it mandatory to go to the repeat sessions, etc.?
It's one of the mandatory trainings, and we have to do it yearly, and if we don't do it, our boss is told, and then we get an email to do it, and that's for all of the staff. That's how it works, and you have to do it. You don't have a choice of, for all the mandatory training. I think I've got 10 mandatory trainings I have to do, and if I don't complete all 10, then Darryl will get an email to say I haven't done it, and he'll email me and say you need to do the 10, and the same for my staff.
There we are. That's one job we know that Darryl has to do. Okay, thank you. Right, I'm not seeing any further, apart from Joanna.
I'm just thinking about the recommendation is the panel to note and agree further updates on the report in January. Thinking about finances and the budget, do we need to have something before then?
Nothing will change between now and then, because we have got the budget. At some stage, and probably it'll be November, December, where the council budget will be presented to you, and that will be when it will be picked up. I think it's November. We need to check, and we can bring it. It'll come through as vote. When do you think it is, Kerry? I can see you.
He thinks it's November too, I think.
Yeah, I think it's November, so it'll come through then. What I would say in the January report, we have asked Seasky to come and look at our co-production offer. I'd forgotten to say that to you, Councillor Hardman. Our co-production offers, and assess at what level we're in. And in January, we're having a safeguarding peer review as well, just to have a critical view of, are we doing what we said we would do?
Okay, so what the panel's asked to do is to note and to ask for that update in January, so we take that as we're asking. But I think it will be very useful for us to see the plan in the context of the budget as well, to, particularly around what's at risk in terms of that delivery. Okay. So, last moments on this paper? Okay, so now we move on to the Children and Young People Health and Wellbeing Survey. I'm going to ask Alison to update us with anything new on this report, and then obviously the panel as usual will ask questions.
Okay, thank you. So the Schools Health and Wellbeing Survey is a survey that's done every 2 years, and it looks at children in years 4, 6, 8, 10 and 12 and asks them a range of questions about their health and well-being and their attitudes to certain things. We're building up quite a body of evidence and data on it now, which is really helpful because it allows us to look at trends as well as priorities. I think it's worth just acknowledging that we get funding from St John's to support this, which enables us to have confidence that we can carry on doing it, at least until 2030. I think it is really important. I'm not going to go into the detail, but I think it's, and I'm sure you've noted, that there are some positive trends since the last survey in 2022, which is encouraging. I think it's also important to remember that 2022, we were just coming out of COVID, and we've been through a really difficult time, and I think everyone acknowledges that that was a difficult time, particularly for young people, so that probably had an impact. There are some areas of concern that we need to be working on, been noted. And also, I think what this also shows is that the issues around inequalities for disadvantaged groups are still a problem, and I think that the focus that we're going to get from Be Well Baines in really giving some more support to that is very welcome and much needed. So I'm going to pass over to questions now, which I'm sure there will be many.
I think there will be. I'm going with Liz, then Anna. I'm probably just going to go around the room, actually. I think Liz first.
Thank you. I have a number of observations and questions to make. As an ex-teacher in my last teaching job, we had the issue survey, and it was incredibly useful. I was head of personnel and social education, so it was very useful in looking at and highlighting some of the issues, some of which we weren't aware of as a school. So it's a very useful tool. You say it's every 2 years, but we're starting already in September 2025. Well, we've already started almost, I would think, in recruiting and trying to, in organising the next shoe survey. So is it still going to be 2 years? That's my first question. Or is it going to be every year? It's disappointing that only, and I think in my day it was the same, 100% of secondary schools have responded, which is excellent, but only 58% of primary schools. Now, I know there are more primary schools than secondary schools, so the first question is, how do we try and get more primary schools involved? That's I think it was a letter from Baines or something, or a letter from us as a panel, or I saw that somewhere in one of the recommendations, but I just wondered, public health, Becky, what are you thinking about there? So the results really fall into two parts for me. One is a very useful tool for schools to see what the issues are within their schools and how can they adapt their personal social education plans and their education plans and welfare plans for young people. But the other one is for us and for public health specifically to see what can we pick up from this. Before going into any more detail, the one thing that stands out for me, and I know, Marcia, you said we're doing a good job, these results show that we're not doing enough about knowledge about sexually transmitted diseases. Is that down to what goes on in schools? I noticed that in one of the reports aligned to this, it said there were lots of great programmes that schools could use. By the way, just a little tiny thing, it said there were no attachments with this report. In fact, there are a huge number of attachments, so I think, except that I was being kind of wiring down and making sure I knew exactly what was going on, I think perhaps in future it might be good to say there are so many attachments with this report. So I think there is an area for public health to take up, and I just wondered, had you outlined areas yourselves that you now think on the basis of these results that you need to work on? To me, there were a number of areas that were concerning, and you have to say there are improvements. There's lots of very positive issues, and me being a very positive person, I would say that yes, there are some really positive issues, but there are areas that are really, really worrying about weight, about bullying, about being tired before going to school, about not having enough to eat. I mean, looking at our free school meals and auto self-enrollment for free school meals, maybe that's going to help a little bit towards that, but it is such a concern that, a substantial number of young people are still going to school hungry, especially
secondary school pupils. So we know the government has brought in breakfast clubs, mainly for primary school children. We just wonder, maybe this is something that we as Baines need to be looking at. And I know there are lots of school issues here which are not public health. I'm just hoping we can pick up a few more of these. And the biggest thing of all are the persistent inequalities right across the board, particularly those with free school meals. But the one group that stands out hugely on every category are young carers. So are we going to pick up on young carers? If you look at those not having enough sleep, those having enough food, those having concerns about their weight, those worried about bullying, young carers are there, usually the highest percentage. And I know we don't have that many young carers, but they spring out as a really important group that we really need to try and focus on. And then ways forward. I mean, what's going to happen because of this? We can't dictate to schools what they do, but I saw that there is a head teachers forum, a meeting of head teachers where this can be raised. But I just wonder what other forums are there for us to address this, because it's a very useful report, but it does raise an awful lot of concerns. Thank you.
Thank you very much, Councillor Howden, and it's absolutely fabulous to hear your passion in all of this as well, and your experience that's coming through, because it's the health of our children and young people is so important, isn't it? I'm going to pass over to Marcia, as she's been leading on that, to answer and address some of those questions. Thank you.
Thank you very much. So just on the first question, it is going to be every 2 years. We start the recruitment now just to ensure that we've got the schools on board, and we start that process and really work with them to try and encourage them to take part in the survey. And we're really fortunate to have the contract with the SHU, with the School Health and Education Unit, so that they are doing a lot of that work and reaching out to schools at a time that works for them. In terms of what we pick up from the survey, obviously we do, in terms of the analysis, it's not only used for schools themselves to identify issues within their school population. We use it from a public health perspective in terms of our campaigns, in terms of resources, in terms of working with wider commissioners and wider stakeholders. And just on one of the later questions in terms of other forums, the information and survey results is also shared and part of the Children and Young People's Plan of the Health and Wellbeing Board. And we've also raised the findings. We go to some of the key partnerships as part of the Baines Community Safety and Safeguarding Partnership, and across colleagues with BSW as well, just to ensure that some of those key highlights are being raised in terms of those persistent issues, areas where there haven't been improvements and where there needs more greater focus. So just to hopefully provide some assurance on that. You raised a lot of the issues that you've raised in terms of sexually transmitted infections and sexual health. We do have our public health in schools programmes, and we have toolkits where we're encouraging schools. When we're sharing their results with them, we are always offering support, signposting to resources. We work very closely with our school nursing teams, so the Child and Family Health Service, who are also there in terms of what are the key messages from the individual school surveys for those schools, and how can we support those individual schools, as well as raising the issues wider. In terms of inequalities as well, just to echo that is something that we are absolutely, as passionate as you are about addressing. The Be Well Baines and the education attainment gap is absolutely looking at inequalities and those wider determinants, and anything more we could be doing and should be doing, and it's going to be that continued priority going forwards. So I hope that also provides some assurance, but just recognising that we are aware this is an issue, and we do use the survey to really look at that. And the other question around encouraging primary schools and other schools, we write a letter. There's a letter that goes to all schools. We then follow up with emails, with telephone messages. There hasn't been any school that's actively said, we don't want to take part. It just, I think the main issue is around their capacity. and just some of the wider pressures. But we are the offer is always open to them, and we do, you know, we're quite tenacious in trying to encourage schools and hear what the barriers might be and to overcome them.
If I can just add, thank you, Marcy. If I can just add one more comment. We are always keen to look at how we can further disseminate the results. So if, you know, as a panel, if you have thoughts and ideas on that, it'd be really valuable to hear them. Marcy's talked through some of the ways in which the results are disseminated, and they're disseminated in a way to try to inform the plans and the priorities and the focusing of other groups. We share it across the whole council when we have a meeting of all the heads of service and the line managers who report to them, as well as through various strategy groups. And I think you get reports produced, don't you, on particular themes?
Yes, yeah.
In order to take a theme on drugs and alcohol to the Drugs and Alcohol Partnership, for example. But we're always willing and need to do more. We can never sort of sit on our laurels on this because it is so important. So any sort of thoughts and ideas you have are welcome. Thank you.
Okay. One of the things that was mentioned was the school nurses service. And I think it would be really useful if we had an update, because I think that would be a really good go-between, if you like, between Baines and the schools. And we haven't really heard mention much of the schools' nursing services. You know, is it still as active as it was once upon a time? And I think an update would be a good idea. And I just wondered, is there anything different that you can do to include more primary schools? Because I know you look like you're doing your best. But is there something else different that you could do? Thanks.
Thank you. We're happy to provide an update on the latest school nursing service.
Just so the panel knows, I think every single one of you is on my list now, okay? So I'm going to start with Anna.
Thank you very much, Chair. I do laugh. My colleague David Harding is a very eminent retired doctor, 50 times published, and he left me this. So we'll try and present. So this is a question from David. His query is around one of the really concerning things, self-harm. So the primary schools have been increased to 17%. His query was public health. I guess his big question he's circled several times is why, but also what are we doing as a public health policy to kind of address that. It's highly concerning. Mine's coming from an absolute physiotherapist point of view. My current job is in respiratory, so I was not shocked but saddened by the vaping rates. I know as a council and the government they did the ban on the single use, but I still walk into shops and they look like candy, don't they? So I wondered if there was some work to be done there about banning the advertisement, for one. But I don't know. That's my question. And also this report, very, very helpful, thank you. But there's nothing on exercise. And if you want to link things, I mean, the obesity crisis is here. My job, I mean, I'm not 40 yet, and I will spend quite a few decades dealing with the obesity crisis in the NHS. So the key here for me is exercise. So if you can get kids into exercise, then the rest of it, hopefully, especially the mental health, but the body image, the self-esteem, lots of it, will follow. I had a terrible experience with PE at school, was a while ago, but talking to young people, they still have those experiences. So could we have something in the survey around exercise, and then could we possibly support them into enjoying exercise instead of whatever it is there? So thank you, there are my questions.
Thank you. So just on the first one around the self-harm, and what are we doing as a public health team? So we do have we work with BSW, and we've got mental health support teams in schools. And as previously mentioned, we've also got our school nursing service who can provide help and support for those that need it. There is always more that we can be done, and it's actually a priority of the Children and Young People's Plan of the Health and Wellbeing Board. And there was just a development session a couple of weeks ago where this issue around emotional health and wellbeing for all ages, but particularly focused as well on children and young people. So it is a priority that we are continuing to work on locally. Just in terms of the second issue raised around vaping, yeah, we have done a lot within, we've done some parent and carer seminars online. We, as part of the Public Health in Schools programme, we've got resources for schools in order to share with their pupils around vaping, not trying vaping. We're also working, obviously, with the marketing as well, and we've recognised, I'm hoping that actually, and I can provide further details when I cross-reference with my smoking cessation colleagues, there has been some changes that actually it won't be possible for young people to be buying those vapes going forward. But I'll find out the latest on that and get back to you on that. And then thirdly, the exercise and physical activity. So the report itself, it just touched on some of the themes, but just to assure you there's a broad range of questions around physical activity, around travel to school, and we do get the results in terms of, so we know that those on free school meals, I think I'd need to double check the figures, but we do get that maybe they don't enjoy physical activity as much. And obviously going back to them Be Wellbeing's, physical activity is a key area of that, and leisure services as well. So these results, as I've said, are shared, and it's kind of the basis and helps form some of those plans that we're working on to ensure that children and young people can enjoy physical activity, not just in school, but outside of school as well. I think, was that everything?
Okay, so Michael, you're next, and then Jess.
Is it possible to get a list of the schools that have taken part in the survey, and whether there's any work that we can do as ward councillors to encourage schools in our own local wards to take part, or firstly thank those schools that have taken part, and then also encourage schools that haven't. Certainly if you were looking for more primary schools to take part, it wouldn't be difficult to go and encourage schools to take part and share with those some of the results that have come out from the survey so far.
Yeah, it's certainly an idea. I just need to go and double check with the team around how much we can share about individual schools. It should be possible. What we will be doing is reaching out to those schools that don't sign up, and hopefully putting those schools that have, in terms of encouraging them, the difference it's made to them in being able to provide support to their student populations. I would just double check whether we're able to kind of publish a list of those involved and those that aren't, because we're very much about bringing them, and I appreciate the offer of you helping to encourage those schools that aren't, but I can just double check whether we're able to do that. But thank you for the offer.
I'm actually going to be very cheeky and just come in with a similar sort of question, which is around, are there any sort of obvious, commonalities, such as, all being part of the same mat, or, or is there good learning that could be used from, one school that was in the mat and has taken part, and maybe that might encourage future take-up as well.
Yeah, thank you. It's something that we do work very closely on with the provider who's responsible for recruiting the schools. There aren't, as I've mentioned, there's no schools actively not being involved in saying they don't want to be. It has just been a question of capacity. But as we're starting the recruitment now for next year, it's definitely something that we're looking at in a lot more detail, and to see how we can support those that haven't been able to do it in the last few years. So we are also, sorry, I should just add, in terms of the mat and different mats, we are going to be writing to the Chief Executive of all the mats within Baines, and there will be an offer for schools that are part of the mat but aren't necessarily part of within the local authority area. The offer will be, there will be a fee attached to it, but if they want to do the survey as a mat, we can give them the results for their mats population. So we're hoping that might be attractive to some of the mats within the area. So it's a new offer this year.
Thank you, Marcia. Now going back to my list, Jess.
Thank you. I had a couple of questions. Thank you. The results were really interesting. Firstly, I wanted to ask how the results as overall compare to national regional trends, and whether there's any areas where Baines is a particular outlier. And then secondly, I noted it touched on some adult online content. I wondered if the survey also covers kind of screen time and social media use generally, and the links between that and high levels of worry and anxiety.
Thank you. So in terms of being able to compare with national or regional, not all areas do the survey, and the provider that we have, I think they operate more in the north and northwest areas, but I can double check that. The survey itself is also it's been developed for local areas, so in terms of those questions and being able to compare to others, it's not able to do that. What we can do is just compare with our, the trends over time within our own population. So in terms of being able to compare national and regional data, that's where we have the kind of national source, you know, the ONS, fingertips data, that's where we would do the comparison. But in terms of the survey results, we're not able to do that. And then in terms of screen time, there's such a wealth of questions within the survey that I can go back and double check. But in terms of making the link between an increased screen time and the mental health, I'd need to double check how that can be analysed and go back to the provider to see how that works.
Thank you. Yeah.
There definitely is more questions around screen time.
Yeah, and picking up on the kind of campaigns around delaying smartphones, it'd be interesting to see whether that has any impact over the next few years.
Yeah. Thank you.
Thank you. So I now have Chris on my list.
Thank you. A number of the questions I had down have been answered already. I'm concerned that the primary schools are missing. And somebody has suggested, ways of trying to get round that. Is it in particular areas or is it particular maths that are missing?
What we can do is look at the recruitment for this year and see if there is a trend from particular areas or particular maths. What we do know is that it's over 50% of the primary schools do take part, so and we will be encouraging those that haven't to date to come on board as well. And I would go back and double check where, if there are specific areas, but on the whole we've been quite assured that the 50% we have got are representative. But we'll always be doing more to recruit those that aren't.
Thank you, Chris. So were there other questions you had? Okay. Joanna and then Leslie.
Thank you. And just picking up on the point about screen time, I mean, it makes me laugh. We've heard today repeatedly about how we're moving from analogue to digital, and yet at the same time we're expecting young people to not be using screens. So we're giving mixed messages repeatedly in our culture about what that is and what that should look like. And we do need to address that out loud in some kind of a way, because I do think we demonise young people in ways that then we are ourselves doing the whole time. It's a useful report. Going back to when you have created a report, you have generated it from a group of people. How are you giving that information back to them to know what they've told you?
So just the concern around screen time, it is something that we are very aware of. And just to assure you that in terms of some of the resources and support that we have, it's around digital as an additional resource, not to replace face-to-face. So just going back to our school nursing service, they've got more face-to-face time within their new service going forwards. And in terms of feeding back, do you mean to the individual participants that have taken part or to the school?
Yes, because I mean, if we've got really interesting information from them, then that should be given back to them, because they are the survey. And one of the things you're saying is, how do we reach groups of people? Well, if you've already reached a group of people and you don't go and tell them, next time they get asked a question, why would they bother? Because nobody bothered to tell them what they said last time, and that they felt that was important. So I can see that the St. John's Foundation have been very generous in supporting this, but could the piece of work that they support also be in making sure that that is returned to the participants?
Yeah, so in terms of just to confirm, the actual data that we get is anonymous, so that we couldn't go back to any individual pupil to give them the feedback of what they've provided. However, I think it's a really good idea to ensure that the school themselves does that you said we did, and to share those themes in an anonymised way that's not identifying any individuals, but just to say what's going well in the school population and what's not going so well, and how that's going to be addressed. So that's a really good idea that I'll take back if it's not already happening.
And then that can be the wider question. And then one of the things is, I don't know if any head teachers have ever been invited to this committee, because one of the things that, we clearly are at arm's length now as an authority with schools because of the whole way that it's been reorganised. But surely the piece of work to do with health
is an issue that then impacts us. So is there any way that we can have a different conversation? I just put my hand up to that. I'll carry on my next question. There, in terms of exercise, Baines has a play policy. I am not aware when the play policy was last updated or looked at, and how do we incorporate that into this piece of work?
Thank you. So just on the play policy, there has been some work. I'm not sure we have a specific play policy in Baines anymore, but we do have work, so working with our colleagues in leisure services, for example, across children's services, education. We're definitely bringing that element to all of our initiatives. And just in terms of the head teachers, we do go to the head teachers forum, not only at this stage where we're hoping to recruit the schools, but also we'll be going back with the key themes across Baines as a whole, so that we do share the learning and they can then have that peer support amongst each other as well. So.
I don't know if it's useful to know, Jo, but Chris Wilford, who obviously attends our children's panel, so he also goes to the head teachers forum and is, in effect, our sort of liaison between this panel and head teachers.
And he does like to ask lots of questions, so maybe we should ask him to give us a small report on that.
We can ask. Yeah.
Sorry, is it just possible, just to clarify, that in terms of the feedback to schools, each school does get their individual reports back, so as a school population, they can look at, the key themes that are happening within their schools, and then they are then able to disseminate that further to their pupils. So just to make sure, in case I didn't make that very clear.
Right. Leslie, I think you're next up.
Thank you, and thank you for the report. And some of my questions have been answered already. And it's good to hear of all the work that's going on in relation to this. I think the concerns for me around the areas of concern that are actually in the report, things like self-harm has increased across all age groups. And I think the vulnerable groups are those receiving free school meals, SEND pupils, LGBTQ plus young carers, BAME, single parent households, etc. And the things that have come out of there, again, are higher self-harm risk behaviours, lower self-esteem and life satisfaction, less physical activity and dental care, and greater hunger and bullying-related fear. So, how are these going to be addressed? And you've talked about feedback going to schools. For me, how are young people going to be engaged in the sort of things they need? This is back to this idea of co-production and co-design, because it's no good preaching to young people who take no notice whatsoever. So it's thinking about doing things in a different way to get messages over, messages that will land. And also, where young people have real worries that lead in them to self-harm, then that they understand there is a safe space to go and where that is. So it's all those kind of things that need to be built in. But it was really good to see some plans around this. You've talked quite a lot about some of the things that are happening, but also to have an update and look at some of the outcomes, because hopefully they will improve in the future. I think vaping, again, is a concern, because more recent reports are showing that young people who vape are more likely to start smoking. So that's been a complete failure. And also, I think asking the question to primary school children, is that been done in the right way? I mean, do primary school children want to fill in a survey? Maybe some of the older ones will. And I think you can see the figures from secondary school pupils are far higher. So maybe looking at that in a different way to gather information there. And part of the gathering information is then about getting some of the messages over as well. Thank you.
Thank you for those comments. Just to come in on so we definitely share the concerns being raised. and some of the key themes and the inequalities as well. Just the final point you raised, sorry, it's just escaped me. I was going to come in, was it? Yes, sorry, just to assure you that the provider themselves will go into the schools and support, ensure that the teachers and those that are present delivering the survey have got full training and being able to support those primary age children, all the pupils completing the survey, to be able to do so. And there is also, they have to stay at the end of the survey, so that if any of the questions weren't clear, or some of the pupils may feel a bit worried or maybe upset by some of the questions, we ensure that the staff remain at the end, and there's clear signposting to if they do want any help with any of the issues that might have been raised.
Anna.
Just maybe it was in the report and I missed it, so I'm really sorry. I know there's been some really interesting data around children that receive free school meals. My question was around other characteristics and whether you ask about that. I mean, I know it's maybe a little bit different with primary schools, but from my own personal experience, neurodiversity would definitely have some links here with maybe challenges with mental health or binge eating or whatever it is. So I wonder if that was a question, and I mean, maybe around sexuality as well.
Yes, sorry, I don't know if it is in that much detail in the report, but there is a range of questions around how young people are identifying, so male, female, or prefer not to say, all those things. So it's absolutely within there, and it's whether that they consider themselves a young carer. All of the protected characteristics are there, so just to assure you.
Right. I have a couple of questions I'd just like to ask. So I'm picking up on that sort of protected characteristic piece from Anna, and I also wondered whether, if we are able to identify voter and gypsy and traveller children, for example, who obviously will have maybe different concerns that might be appropriate for schools to seek to be addressing, which actually leads me to my next point, which is around what happens now. So it's all very well taking this and us having comments about it, and I know you did ask for some sort of indication of what we thought should happen next, but I think it's also very important that we know what does happen next, and with that in mind I would like to ask for a sort of like a follow-up report to come to whichever is the most appropriate panel. I don't think maybe next month would be best to do that, but perhaps the next one for children's services, which I think would be, is that December or? Yeah, December. Just so we get some sense that that this matters, that change is being done, and then so the next time the report happens or the survey is done, actually we might be in a better position, and actually we won't have a third of pretty much every single age group, feeling dissatisfied expressing life dissatisfaction. So I think that's really that's really worrying and quite upsetting, I think, for all of us. And then I wanted to ask some questions around the young carers. So again, we spoke about the young carers and what they might experience. I think this is picking up on what Liz was talking about. So again, what's going to change? How are their lives going to be improved based on what their responses have been? I think that'll do for now. I'm sure there's other things I'd like to ask.
Thank you, Councillor. Those are really helpful suggestions. I guess one thing just to put across is that the responsibility for responding to everything that comes from the survey doesn't lie with the public health team. Our responsibility is to share. So this is part of understanding the needs assessment, understanding the health and wellbeing needs of children and young people. It forms part of the strategic evidence base, so it's part of that strategic evidence base. Our role is to try to make some changes in those areas where we have direct control over certain things, whether that's around our influence in smoking, physical activity, healthy eating, etc. Where areas lie outside of the direct management of the public health team, our role is around influencing and sharing the information with other partners and with other partnerships. So we can certainly bring back what we can. It may be that we need to write out to many of our partnerships and ask them what they've had an opportunity to do as a result of receiving the survey results, and we can look to feed those back. Would that be helpful?
I think so, and I think it will also, you know, there'll be other work that's being done, such as the HAF, for example, where, you know, perhaps this could also be fed into to see how improvements can be made to those groups of children who are accessing, you know, that kind of work. Right, and now we're going to move on to the minutes, which suggests that the meeting is drawing to a close. Right, so are there any comments on the minutes? Has anybody identified anything that is wrong in the minutes? In which case, then, can we take that as being an accurate representation of that meeting? I did have a couple of points I wanted to ask, which were around actions from there, but I think that will feed into our work plan. So can I just check that we're all happy to note that they were accurate? Good. Right, and then we can move on to the work plan for the panel. Oh, sorry, Leslie.
Yeah, can I just pick up a couple of things? On the music pilot project, which I think is a really important piece of work, I have sent various pieces of information through to them about possible funding opportunities, which, you know, obviously they're going to need. And I think, again, it's around Culverhay, really. So I think David picked it up earlier. But what happens if that is not approved? And I think, obviously, we need to be looking at that carefully. Thank you.
No, thank you. I think that will feed into the work plan because it's really an update, isn't it, on where we are with that Culverhay funding, and it's on the list, as Clary has pointed out to me. So, right, back to the work plan. So we've got a number of things from our work today. So we've spoken about the CQC action plan that we expect in January, COVID and vaccinations. So again, I think that's not next, it's the November meeting. And possibly the play policy, I think, maybe. Would that be something of interest, so we know whether there still is a play policy, and if so, you know, what does it look like? What's it doing? And I do think there was another item that I was expecting to see at this meeting, and
employment service,
home to school transport and modern day slavery was another one. And Leslie.
Yes, Chair, it was the homeschool transport costs, which are tremendous.
Which is on our list already, so we're expecting that at the next meeting. Okay, so Kerry's telling me that it's actually also going to the corporate panel, so, and I'm sure if any of us want to attend, Kerry will make sure that we know when it is, so we can attend. Are we allowed to ask questions of that meeting, or will it's just really just an observation role? Perhaps that'll be down to the chair.
Yeah, exactly.
Liz.
Free school meals, auto-enrolment update?
Yes.
We could ask Paul May to do
We can have that as part of Paul May's report. Yes. Have I missed anything? Michael.
It may have already happened, but I know that the community, has there ever been any feedback to this group on the work of the Community Wellbeing Hub and the Live Wellbeings? Because actually, I think they're both such essential services. It would be really, I know they've just celebrated some big achievements, and I'm just wondering if that would be appropriate for them to come and talk about what they've been doing, if that's possible.
I think that would be a very good suggestion. I think we've had them at our meeting a number of times around budgeting in the engagement work that has been happening, but perhaps not so much in terms of what they do. And as you say, what they do is very good. And I think Suzanne said that they were an exemplar of that joined up work. Liz again.
Me again. We did say somewhere in the minutes, I think, that St Michael's Primary School, we'd like them to come again and give us an update, or maybe that could be part of.
Is this about the music?
It's about the music.
Yes, because I did have that on my list as well,
Yeah.
which was around, which I'd like to be incorporated within either Paul May's update or else separately, which is a report on that music project, what happened about the funding.
And there's one last thing, the attainment gap. I think we said we wanted to include the wider determinant project from Public Health.
Yes. Have you made a note of that, Kerry?
We're due to take the annual school performance report next meeting, Chris. Yeah, so...
Okay, so obviously, as usual, if there is anything else that occurs to you that you think should be coming to one of our next meetings, then please let myself or Kerry or even Mark know as well. And on that note, I'm going to close this meeting. So thank you everybody for attending, and I hope